Ascites. Ascites refers to the pathological accumulation of free fluid in the peritoneal cavity. It is most commonly a complication of cirrhosis and portal hypertension, but may also be caused by malignancy, cardiac failure, infection, or other systemic diseases. Peak incidence. Ascites is most common in individuals aged 50 to 60 years old. The majority of cases in the UK are due to decompensated cirrhosis. Pathophysiology. Ascites develops as a result of a combination of hemodynamic, hormonal, and renal abnormalities, most commonly secondary to portal hypertension from liver cirrhosis. Portal hypertension increases hydrostatic pressure in the splanchnic circulation, driving fluid into the peritoneal cavity. Hypoalbuminemia, due to impaired hepatic synthesis, lowers plasma oncotic pressure, further encouraging fluid transudation. The resultant arterial underfilling is sensed by baroreceptors, leading to activation of renin-angiotensin-aldosterone system, causing sodium and water retention, sympathetic nervous system, causing vasoconstriction, and antidiuretic hormone, ADH, promoting free water retention. Together, these responses lead to expansion of extracellular fluid volume and worsening ascites. In advanced stages, impaired lymphatic drainage and increased capillary permeability contributes further to fluid accumulation. Symptoms: abdominal distension and discomfort, early satiety from the pressure effect on the stomach, breathlessness due to diaphragmatic splinting, weight gain secondary to fluid accumulation, and occasionally loose stools or vague gastrointestinal symptoms. Signs: typical examination findings include shifting dullness. This is change in percussion tone with patient repositioning. Fluid thrill. This is an impulse transmission across a fluid-filled abdomen. Associated findings based on etiology: chronic liver disease, jaundice, spider nevi, and palmar erythema. Cardiac causes: peripheral edema and raised jugular venous pressure, JVP. Diagnosis: clinical suspicion is confirmed by bedside and laboratory testing. Blood tests: full blood count, FBC. This can show anemia from chronic disease or malignancy. Leukocytosis, which can suggest spontaneous bacterial peritonitis, SBP. And thrombocytopenia, which can occur from portal hypertension and hypersplenism. Liver function tests: elevated ALT or AST in liver disease, raised bilirubin in cirrhosis or malignancy, low albumin in chronic liver disease or nephrotic syndrome. Urea and electrolytes, UNEs, raised urea and creatinine in hepatorenal syndrome, hyponatremia, which is dilutional due to RAS activation, renin-angiotensin-aldosterone system, and hypokalemia due to diuretics or secondary hyperaldosteronism. Coagulation profile: prolonged PT and INR in liver dysfunction. Other relevant blood tests may include amylase and lipase, which can be raised in pancreatic ascites, and alpha-fetoprotein, AFP, if hepatocellular carcinoma is suspected. Diagnostic paracentesis: always perform in new onset worsening or suspected infected ascites. Acidic fluid analysis, cell count and differential, neutrophil count over 250 cells per millimeter cubed. This suggests SBP, culture and gram stain, and albumin concentration. A serum ascites albumin gradient, SAAG, is equal to the serum albumin minus the acidic fluid albumin. High serum ascites albumin gradient, over 1.1 gram per deciliter, can indicate portal hypertension, for example, cirrhosis, heart failure. Low serum ascites albumin gradient, less than 1 gram per deciliter, can indicate a non-portal cause, for example, peritoneal carcinomatosis, TB, and pancreatitis. Imaging. Ultrasound abdomen to confirm the presence of fluid. This can guide safe paracentesis. CT abdomen. This is reserved for suspected malignancy, TB, or diagnostic uncertainty. Complications. Complications of ascites include spontaneous bacterial peritonitis, SBP, hepatorenal syndrome, refractory ascites, paracentesis-induced circulatory dysfunction, especially after removing over 5 liters without albumin replacement, dilutional hyponatremia from fluid shifts or excessive diuresis, and umbilical hernia or hydrothorax. Management. General principles. Treat the underlying cause, for example, cirrhosis, malignancy, heart failure. Alcohol cessation in liver disease is critical. Daily weight monitoring. Aim for less than 0.5 kilos per day loss without edema and less than 1 kilo per day with edema. Dietary measures. Restrict sodium to less than 2 grams per day. This is about 90 millimoles of sodium. Fluid restriction only if sodium is less than 125 millimoles per liter. Diuretic therapy. First line, spironolactone 100 milligrams daily, can titrate up to 400 milligrams. Adjunct, furosemide 40 milligrams daily, can titrate up to 160 milligrams. Aim to maintain a 100 to 40 spironolactone to furosemide ratio to preserve potassium balance. Therapeutic paracentesis. For tense or symptomatic ascites, if removing over 5 liters, give intravenous albumin, 8 grams per liter removed to prevent circulatory dysfunction. Provides short-term symptomatic relief. Advanced therapies. Refractory ascites. Consider transjugular intrahepatic portosystemic shunt, TIPS, in suitable patients. Liver transplantation is definitive in eligible patients. Prophylactic antibiotics. This is indicated for patients with prior SBP, acidic fluid protein less than 15 grams per liter, and advanced liver disease. Common agents, norfloxacin or ciprofloxacin. That was the full video, and there's hundreds more like it waiting for you at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today